Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt. I am the managing editor for VBC Exhibit Hall. So I'd like to welcome all of you to today's live webinar hosted by NetHealth. Now, this is actually part two of a two-part series called All Roads Lead to Value-Based Care. And this one is focusing on value-based care across payers. And the first one was an intro to value-based care. But don't worry, if you didn't see the first one, you won't be left in the dust. And what we'll do is also make sure to share the link to the first one when we send our little thank you note after, so you can catch up on that as well. But very excited to hear from our speakers, who I will introduce momentarily. But a couple items of note before we get started. Everyone has joined today listen-only mode, so this is a traditional webinar format. We can't see you or hear you, so don't worry about that. But we do want to hear from you. And so during the Q&A, which we're going to have a little time for some questions towards the end, you're going to have an opportunity to ask our speakers some questions, and we hope that you do. So if you have a question at any time, you don't have to wait until the Q&A in order to do that. So you can use your control module that has a space for questions, so which is different than the chat. But go ahead and drop your question there at any time, and we're going to get to as many as we can today. If we don't get to yours for some reason, don't worry, someone will reach out via email afterwards and make sure that you get your questions answered. So without further ado, actually, before I introduce the speakers, one last note that it is being recorded today. So the session is being recorded. So when we're done, you'll receive an email from us in about an hour probably after the conclusion, and that will have a link to the recording and to the slides, and so you can review the session at that time. So now let me quickly introduce our speakers today. We have Miss Erica Archuleta, and she is the Payer Analytics Solutions Director with NetHealth. And we also have Miss Janine Savage, and she is the VP Post-Acute Analytics Solutions. And I believe Erica is getting us kicked off, so welcome.
Thank you, Garrett. Thank you everyone for joining today. This is our second, as Garrett said, part two of our series of 4, and we're talking about value-based care across payers. The learning objectives for today's session, we're really talking about understanding the value-based care across payers, as well as the rationale to transition to value-based care, strategies for promoting it, and really the importance of data analytics and sharing. Let's get to a poll question. Here's our first poll question. Do you currently build performance targets into your provider contracts? A, yes, B, no, and C, not applicable.
Okay, so the polling question is up on your screens now, and this is anonymous, by the way. And so what we're going to do is show the results here in a moment, so you can kind of see where you stand among your colleagues. So we're going to give just a few more seconds here to answer. And again, this is just a select one. And of course, not if it doesn't apply to you, yes or no. And most of the results have come in. We're going to give it about 5 more seconds. 5, 4, 3, 2, and 1. And I'm going to go ahead and close it down now and share the results. So here we go. We just got a couple questions rolling or responses rolling in here. Okay, I think they're all in. I'm going to close it down. All right, Erica, are you able to see the?
I am not, Garrett. Could you please read the results to me?
I can. So we have 58% with yes, 5% with no, and not applicable, we have 37%.
Okay, great. That's very interesting. I was anticipating with some. I'd really like to know more about some of them that aren't doing it so far, if it's not applicable, which is great. I love to always know the different audience. So thank you for responding to that. There we go. So one of the things that we're like, why value-based care? And I think what we've definitely seen is that CMS is definitely moving towards this in 2030. They've really put strong indication across, multiple notices. They've developed different strategies, different models, and they've really kind of doubled down on this commitment, which is why we're talking about value-based care, is because CMS is really driving this. Let's talk about CMS a little bit. So CMS, which is the Centers for Medicare and Medicaid, is the largest healthcare payer in the United States. They do approximately 63 million Americans rely on Medicare. 89 rely on health benefits through Medicaid. So it's a very, very big payer. Therefore, a lot of the direction where value-based care is being driven is really by CMS and what they're putting forth towards their respective partners, whether it's the federal regulation that they're putting forth or to these states. Let's talk a little bit about Medicare versus Medicaid. I know it kind of seems often, my mother always tells me, she says, oh, Eric, I have Medicaid. I said, no, Mom, you have Medicare. And so I always like to tell people, because they are very similar in terms of how they're stated, but they're very different programs. So first, Medicare is really an age-based program that's really for people and individuals that are 65 and above, or people with disabilities. What it is also, it's administered by the federal government, and there's multiple parts of Medicare. First, there's Part A, which is really hospital coverage. Part B, which is really your medical coverage. C is Advantage plans, and D would be your prescription drugs. Now, people tend to have a combination of that mix when it comes to Medicare. You know, not necessarily, some of them have all parts, some of them have that combination. When we talk about Medicaid, it's a means tested, and really what that means is that it's really for individuals that qualify or meet specific criteria to qualify for Medicaid. Medicaid is really joint venture between the states and the federal government. These states are able to have flexibility in the program of which they administer. They have their own program rules, their eligibility, and their benefit structure. What you'll often hear people say is that if you've seen one Medicaid program, you've seen one Medicaid program. And that's often very true, because the federal government gives states the flexibility to design it based on what the needs of their respective states are. They have a broad range of healthcare services. Typically, your physical health, your behavioral health, dental care, there's some sort of flexibility, and long-term care. Definitely flexibilities, and the coverage amongst each of the states really varies. What states often do is they get what you call a federal match from the federal government, meaning they put up some sort of state general fund that is matched with federal dollars. Then that totally gives them their complete budget for Medicaid. So that's why it is a joint venture. They also really work with CMS to really, design the program, as well as get a regulatory authority to implement it. There's also private insurance, and what we often hear with private insurance, which many people are familiar with that, you have that really in coverage with, you're either purchasing it from a health exchange independently, through your employers, multiple avenues to kind of purchase private insurance, but that is something that you tend to pay for out of your own dollars. Often people have a what you call Medicare supplement. So there is private insurance that is a supplement to existing public health insurance, such as Medicare. You hear that. For private health insurance, you usually pay premiums to the health insurance company and some sort of copay. The coverage is also really varies on the respective policy that you have and the coverage on your policy. You may have to have some sort of co-insurance with that and co-payments after meeting your deductible. Typically in Medicare and Medicaid, you don't have a deductible. In some cases, you do have some co-payments, but it's not necessarily consistent. It just depends on your specific state and what your coverage is. So that's a little bit of the difference of the payer landscape on what you're seeing. Let's go back to talking about CMS. CMS's goal is to really transform the health system. One of it is about equity. We often are hearing about equity. We're hearing about person-centered care, social determinants of health. They're really administering this from a federal level, and they're really talking about this, to the entire country and working on equitable outcomes. You've seen some of the rules that CMS is promoting with CMMI, with the Innovation Center, which is really talking about different models of which they want to implement value-based care, because what we've learned is one size does not necessarily fit all, and there's multiple opportunities. What CMS also does in the Medicaid landscape is they really approve the state Medicaid VBP programs. You either do that through what you would call an 1115 innovation waiver. You have directed payment programs, such as a 438.6 that's operated under managed care. You also have state plan amendments where people are building that into the Medicaid state plan that each respective state has, and they're putting a variety of different quality outcomes into place in order to help these states move towards that value-based care. You're seeing it as you're also seeing with the proposed rule recently that came out in about May of 2023, where CMS is really looking at trying to do a more alignment amongst the programs. For example, Medicare short-term nursing facilities VBP program, aligning that with the state. Again, there's a little difference in the coverage that each payer has. For example, what Medicare covers in terms of nursing facility care, what Medicaid covers, and some of the overlap or the transition that's covered. But what you're seeing is CMS is really genuinely trying to align some of those, to kind of alleviate the burden on providers, as well as kind of give more incentive to the payers as well in treating these really kind of vulnerable populations. When we talk about policy and regulation, what we've seen is CMS really setting forth. One of the ways that they've done that is the Medicare Access and CHIP Reauthorization Act, otherwise known as MACRA. It introduced really quality payments and the MIPS program, as well as alternate payment models for Medicare reimbursement. That was something we saw at the federal level that was really pushed forth. And really working with providers and payers to really make these models work. It was to align the value-based care and to really give incentives to providers to participate, because really it's about aligning the incentives, and CMS is really well versed on that. Medicare and Medicaid are really instrumental in driving, because they're the largest payer, they are really instrumental in driving value-based care. They've also introduced Medicare shared savings programs. As I mentioned before, the Center for Medicare and Medicaid Innovation, which is also known as CMMI. They've also really worked to promote accountable care organizations, ACOs, also really talking about these initiatives. You also saw some reform of actually current laws, like they did the Stark reform, which really was changes surrounding, the value-based care arrangements and more flexibility, and to really give providers more leeway to collaborate, share resource, and not be in any type of violation of any particular statute. You've also seen states, as I mentioned before, each Medicaid program is its own kind of entity, as each states have flexibility. Some states operate under Medicaid managed care. Some still operate under fee-for-service. They've really worked hard to incentivize care coordinations, preventative service, and different innovations among the states to really align it and to really, like I said, be innovative, reduce the administrative burden to providers, and incentivize payers to really kind of move towards this. You've also seen government agencies really doing quality metrics and reporting. There's really a lot of standards that they're setting forth. There's requiring healthcare providers to track and report quality measures. We hear a lot about HEDIS and HCAHPS and patient satisfaction, clinical outcomes. We really talk a lot about evidence-based practices. We've also talked really a lot about data interoperability and exchange, about really being able to talk about having the data talk to one another, the exchange, having that in between the payers, the providers, being able to get the data and the coordination of it, which hasn't always been easy, but it's something very much that you're working to evolve, either through health information exchanges or other, even with the Medicaid management enterprise system replacement, trying to align all of those systems to talk to one another, to really have greater transparency and really be able to measure, set benchmarks, and just be able to evaluate where we stand. One of the things that we've had with value-based care is really what are the core principles. One of it is really the emphasis on patient outcomes. It's really, are we having more quality versus quantity? What are we seeing? Are we seeing patients get healthier? Are we seeing them stay out of hospitals? We're really talking about their satisfaction and improving their quality of life, reducing the complications from hospitalizations or illness and chronic conditions. We also really have talked about, promoting what is quality and what is safety, and really basing it on really evidence-based practices. Focus on improving patient outcomes and preventable harm. We also talk about cost efficiency when it comes to value-based care, is really optimizing the resources and reducing unnecessary healthcare spending without really compromising patient outcomes. Really looking at that cost-benefit ratio, return on investment, and making sure that we are getting people healthier and we are really optimizing our resources. And one of the key is care coordination. I think this is really about collaboration, transfer of care, really a seamless transition amongst the care, getting the right services at the right time and really not being fragmented. That's really the goals of care coordination, is really that seamless transition and really a comprehensive set of services. And again, be patient-centered approach. That is really what we're seeing, is really talking about here is the individual needs. We talk a lot about health equity in this. We talk about a lot social determinants of health, and really designing programs that are patient-centered, that really meet the respective population and the respective patient's needs, and that we meet them where they are. Very often it's being able to say, what are their respective needs? What do they need? We talk a lot about housing, for example. That has a big outcome if you're going to discharge someone from a hospital of, do they have housing to transition them? What are their needs? Do they have transportation to get to appointments? All of those social determinants that really help us and understand and indicate ways that we can have better quality of care for our members. Also, prevention and population health, that's a really big thing, is being able to reduce the burden, reduce chronic diseases, and really being able to understand each respective population and how we can meet them where they are and what their respective needs are. Data, data, data. Now, to me, value-based care is all contingent upon the data. Data-driven decisions, having the ability to measure where you are. Where are you? Where did you start? I think what we recently saw with CMS's proposed guidelines that I previously spoke about was they're really talking about baselines, improvement. How do you benchmarks? How do you really measure that without data? And being able to allow both payers and providers to really make data-driven decisions, really based on evidence-based decision-making, really having the technology in place, really having the methods in place to really measure performance. I mean, that's the key right there, is it really data. I can't, I think I always go on, is it's the devil's in the data, and we don't know what we don't know until we're really able to look at the numbers and see who we're choosing. And there's so many different data elements out there, but being able to bring it together to drive that decision making. What are strategies that we use to promote value-based care? One of the things is alternate payment models. I think these models really incentivize, providers to really work together to improve that care coordination and the outcomes. It's not really your basic, in the previous days in the fee-for-service model, we really looked at billing CPT codes, HCPCS codes, but the new models are really about doing different models where you have bundled payments or different methodology that really focus on, not only quality, but cost targets, and really foster a focus on value and efficiency. And again, I go back to data, data, data. Data sharing and analytics are really key in this, because if you really don't have data, can you really measure the progress? Can you measure the targets? Where did you start? Where did you go? Were there areas of improvement year over year? Were there areas that you improved 1 year or you didn't? But being able to break that and really look at the data from really different areas has really been one of the strategies to promote the value-based care. And I think it's given the tool to both the payer as well as the provider, that you have a transparent look at the data so you both know where you stand. I think one of the things with value-based care is that there really should be, at the end of the day, no surprises. I think, if you ask CFOs kind of get a little scared sometimes, because on value-based care, if they don't have the particular data and they don't have the information, can they do the proper projections to know what their needs are to make the company efficient and the provider group efficient, right? Same things on the provider end. And really having that data to really drive that and being able to project in the predictive analytics. And I can't speak Keely. I think that's the biggest key and probably one of the most important strategies I see in value-based care is really having the transparent data. Also, your quality improvement initiatives. I think it's collaborating both the payers and the providers to really drive those quality improvement initiatives. You know, as I talk about in the Medicaid realm or in the Medicare realm, we often have it like in Medicaid, you have to report in your quality improvement strategies that you really have to put forth. So the payer has some quality improvements that then they have to really work with the providers to drive. And it's really looking at the initiatives and the pathways to develop these and the clinical guidelines to implement these practices and really have these initiatives so that you both are able to work together, because at the end of the day, it's really about our patient outcomes and how can we improve that for them. Also, it's looking at your risk stratification and really assisting providers to really be able to identify the high risk patients and help them with care management, being able to coordinate care, address specific needs. And this approach really helps really reducing those hospital readmissions, the complications, and the overall cost. So that's a really important strategy of both payer and provider collaboration, is being able to really review that. That really goes back to the data, but being able to identify those patients and what we can do with them and how we can best assist them and meet them where they are and work to improve their quality. Also, it's long-term contracts. I think that you can't just do this in 1 year. I know I've got a lot of experience in the directed payment realm where CMS, it's year over year. We tend to do them in an annual renewal. But what we're really driving in that is you really want a long-term contract goal, because sometimes we don't see improvement in the first year or as great as we want. It's a year over year. But this really incentivizes payers and providers to really enter into long-term contracts to really incentivize participating in value-based care so that you can constantly, move that nodule and address things and make that investment in infrastructure, make that investment in care coordination, make that investment in patient engagement efforts. Care coordination is really key, and knowing that if you have a long-term contract in place to really incentivize this, that you can really move forward with it. You also have other strategies include public reporting. A lot of payer organizations, I see this often both in Medicare and Medicaid, we have to really publicly report quality measures, cost metrics, expenditures. There's a lot of report on what are we spending, what are the performance, what does quality. So it's really, this is to encourage transparency so that everybody knows where you stand, giving patients the option to know, like, where does this provider stand? What are some of the costs? What are the reputations? These are the things that with public reporting is really incentivizes, is really having this, it encourages actually the public reporting, because it kind of gives public trust. We also talk about, alternate payment models. I talked about this previously in another episode, but really want to talk about that. It really is that transition from fee-for-service to improving quality and value. That's really what you're seeing, and it really rewarding providers. We really talk about really probably 6 high-level areas of providers. And we kind of start with pay for performance. And that's really where you still utilize the fee-for-service system as your base, but you give an additional incentive to providers for meeting particular performance metrics and outcomes. We've also talked about, accountable care organizations, really giving groups of healthcare providers, they assume the responsibility for the cost and the quality of care for a defined population. This kind of goes into some shared savings and shared risk. There's a lot of upside and downside risk in the accountable organization. Capitation. This is really a fixed amount. PMPM. This is really having the, often we see it a PMPM, which is a per member per month or a per member per year, but this is a really fixed cost, regardless of the number of services rendered. We see that where the providers, this is their full risk at this particular model, where they're responsible for delivering the comprehensive set of care within this budget. You've also seen bundled payments. What we talk about in bundled payments is a single payment for all episodes of care. We often see this in replacement surgery, maternity care. This is where you give a bundled payment for entire service. We've also seen some quality withholds where the providers are really withheld at first, and then they get the money if they meet a specific quality or cost targets. Another one we see is patient-centered medical homes, really where PCMH really receives additional payments for really a comprehensive and coordinated patient-centered care. This is really important, and we see a lot of PCMHs starting to arise more. And it's, all of these models are really great places to start, or even to, to strive for when you're trying to develop your value-based care. And talking about that, let's have another poll question. What alternative payment models are you currently using or considering in your practice? Please choose all that apply. Pay for performance, accountable care organization, capitation, bundled payments, or patient-centered medical homes.
Okay, so it is up on your screen now for you to vote. And again, this is anonymous, so don't worry about that. But we do want you to be able to see where you stand among your colleagues. So as soon as you fill this out, then we're going to share the results so you can kind of see what other people are utilizing. So we're going to give it a few more seconds as the results are still coming in. And so this is all that apply again. So you can go ahead and if you're utilizing all of them, go ahead and select all of them. Okay, so I think most of the results have come in. I'm going to give it about 10 more seconds. And then we will go ahead and share the results. So we're going to go ahead and close it down in 5, 4, 3, 2, it's a long 5 seconds, and 1. And I think everyone has answered, so I'm going to go ahead and close it down now. And I'm going to share the results. Okay. All right. So Erica, I'll read these out for you.
Thank you.
And okay, the first one is for pay for performance, we have 52%. Accountable care organizations, 80%. Wow, that's great. Capitation, to some degree, is 37%. 43% for bundled payments, and 39% for PCMH.
Great, that's very interesting. I'm proud to see that the pay for performance is being utilized, that all of them are, but those percentages are impressive. I appreciate that.
Yeah. All right, so I'm going to go ahead and pull this back down. All right.
All right, so now I'm going to take us through a little bit deeper dive about data and analytics. Data and analytics are really the key to developing and implementing effective value-based care programs and models. And I've often heard it said by providers and payers alike, they feel like they're in some cases drowning in data, but they're in a desert when it comes to meaningful insights from that data. And that's where analytics comes in. So we're going to talk about some of the key concepts today that help us enable the development of effective tools that help give providers and payers that insight that they need in order to successfully navigate value-based care, to make better informed decisions, and ultimately to improve the quality of care that's delivered and the effectiveness of that. So these are some of the really important concepts around data and analytics. We'll start with data aggregation. In some cases, I'm sure you feel like you have a lot of data, and in other cases, you probably feel like you're lacking key data that would help you make better decisions. And data aggregation is one of the most important activities that support care coordination in particular among providers and payers.
Oh boy.
So data aggregation involves
There we go.
collecting health information that can be from various sources. That may include electronic health records, claims data, patient self-reported data in some cases, and other types of data as well. And aggregating this data into a central repository or other technological means to be able to access it and use it for model building and analytics is really crucial to supporting two very important objectives. The first one is patient engagement. In order to analyze patient data and their preferences and be able to show those things in an effective way to payers and providers, that helps them personalize the care that they're planning and delivering to their patients and members. And that really leads to better patient engagement and patients and members having a stake in their own healthcare outcomes, and also things like adherence to treatment plans. There's some really good research out there that shows us that the more engaged a patient feels in their own healthcare, then the better their outcomes will be. The other important objective is care coordination. Data analytics support successful transitions of care. Real-time information helps decrease medical errors and improve the handoffs between different types of care providers. We can see patients' history and other important information about them to help those teams work together more effectively and deliver better care. The second concept is interoperability. Erica talked about this already a little bit. We often talk about, we just need our systems to talk to each other. There is a wide variability currently across the country, across providers, across different types of settings, and it varies from region to region, state to state. And in some cases, we have very robust networks of technology that help providers and payers exchange data. In other cases, we really lack that, and there isn't good participation. But we are moving closer and closer to being able to exchange more data than ever before. We have more standards for data exchange than we've had before, and there are incentive programs that can help defray the cost of those types of technology. So enabling a comprehensive view for a given provider or a payer at a given time to really understand a patient better and have a better, more comprehensive view of their history and their needs helps deliver better care and is crucial to the objectives of value-based care. Risk stratification is a concept that we often build into analytics to help identify a patient's likelihood of developing perhaps an adverse event like a fall, a pressure ulcer, an infection. It can help us understand where we need to focus our resources and where we can use our resources most effectively. One of the things that we see sometimes is that clinicians, and I'm a clinician by background, clinicians are pretty good at identifying patients that are at high risk, but they're not as good at identifying patients that are at low or moderate risk for certain adverse events and complications and conditions. And therefore, those patients sometimes tend to fall through the cracks. We tend to focus our attention on the patients we know are high risk, and sometimes things like readmission rates for a nursing facility, for example, can actually be driven by the low-risk patients that are becoming readmitted to the hospital, not the high-risk patients. So it's really important to understand a patient's risk for a given outcome and be able to target our interventions based on the reasons for the risk and be able to focus our resources and our systems and processes on where they can matter the most, essentially. Performance measurement is absolutely crucial, of course, to value-based care. And data analytics are what is used to determine whether or not performance targets have been made. And we can look at comparing a provider's performance compared to benchmarks and quality outcomes, as well as cost and utilization outcomes. We may look at different types of outcomes. Example, readmission rates, preventative care adherence, certain structural measures or process measures that we know are impactful to outcomes and that we want to make sure providers are meeting. Quality improvement. We often think about quality improvement at a provider level, and it's true that we look at performance measures most often at the provider level and evaluate their performance at that level. But quality improvement is actually made at the patient's level, at the member level. And in order to have better provider outcomes, we need better patient outcomes. It seems like a simple concept, but sometimes we kind of lose sight of that. And one of the things that is absolutely crucial to quality improvement is closing care gaps, being able to see where we are not maybe meeting evidence-based practice standards in preventative care or chronic disease management, or in the management of acute conditions, where we know we can impact an outcome at that patient level. Population health management, of course, is its own discipline, and we could talk for hours just about population health. But analytics tools are really crucial in value-based care programs and models in understanding outcomes across populations of patients or members. So in order to understand the needs that we have across our population and the kinds of services and programs that might be helpful to better manage those populations and therefore affect outcomes, including utilization, we need to be able to understand the characteristics that a population has, the risks that they have, and how we can target some of those risk factors, contributing factors across the population to help improve the health of that population. Continuing on, resource allocation, talked about this a little bit already. It's very closely correlated with risk stratification, but understanding beyond that, understanding the utilization of patterns across utilization types of measures like ED use and specialty care physician use and hospitalization can help us understand the resource needs that providers have, and that also we can have perhaps try to fill or supplement any knowledge or skills development that a provider might need as a plan, as a health plan or a payer. So the point here for resource allocation is to target where we might have waste or where we might be spending resources unnecessarily through a data-driven approach, and focus or target the resources that we have to where they will make the most difference. And what we see right now is everybody is struggling with resources. Providers, payers, everyone is struggling with resources. There just aren't enough because of unprecedented, that word gets used a lot, but workforce shortage. So resource allocation considerations, I think, are more important than ever. And this is where we can really use our analytics to help drive us in the right direction. Predictive analytics are very powerful. They can help us forecast what patient and member needs will be and identify which patients, which members are at risk for conditions that we know will cause worse outcomes. And the whole point here is to intervene proactively in an individualized way, to focus on the reasons those patients or members are at risk, and to prevent those adverse events to the degree possible, or if it's not possible to prevent them, to minimize the complications and the outcomes and intervene early. Financial analytics, of course, I operated in a not-for-profit environment, and I used to say all the time, we can't meet the mission if we can't make the margin. So every single organization, provider and payer alike, has to be concerned with financial outcomes. And when we talk about value-based care, are we investing the right amount of resources into these programs for the return that we're seeing? And that can be expressed in terms of cost savings, shared savings, depending on the type of VBC model or payment program. We like to look across different types of outcomes to look at financial effectiveness, things like looking at clinical outcomes correlated with utilization outcomes and cost, because that's really the whole picture, right? I think one of the mistakes we often make is to look kind of in a siloed way at an outcome and draw conclusions about it. But we really have to look at the different types of outcomes taken together to tell the story of what the true financial picture really is and the impact that the efforts are having. So from a compliance and a reporting standpoint, data analytics certainly help us determine if we are in compliance with the requirements of some of these programs, which can be very complex, as Erica alluded to. For example, directed payment programs in the Medicaid program have very extensive requirements. We provide support with those kinds of preprints, so we get intimately involved in those. And having the analytics to really evaluate your outcomes and whether or not you are in compliance with any regulatory authority requirements or even your own internal compliance considerations as well. Feedback loop helps ensure that we are evaluating from start to finish what's happening in a particular program or model, that we're adjusting our strategies and our tactics as needed. And so we usually recommend a whole different set of evaluative criteria based on certain analytics to determine, are the goals and objectives of a program being met? What are your goals and objectives, and how are you going to evaluate whether or not they're being met? Is something to start talking about in the very early day, in the early times, when you're just designing a program, not when it's already been up and running. And then, of course, adjusting that as needed. And data security and privacy, I'm sure we could all agree in today's environment is just more important than ever. We have to be sure that our patient and member data is secure, and we have to implement, whether we're doing ourselves and utilizing our data or using a third party to do that, to be sure that they're using the highest security standards. For example, in our company, we use HITRUST. We are HITRUST certified, which is kind of the gold standard for security and the highest bar you can achieve. To kind of wrap things up, the transition to value-based care is a very complex process. Value-based care is many things to many people, but the commonalities are ensuring that we have an investment in data analytics and technology, that we encourage and facilitate collaboration among all of the stakeholders, and focus on patient-centered care. And in that vein, when we focus on those things, we create, by definition, with our outcomes, we create a different healthcare system. We transform one that delivers better outcomes for our patients, for our members, while still controlling costs. And this, as Garrett said, is the second in a series. We have 2 more webinars coming up where we're going to talk about some real-life examples of how providers, through value-based care, and payers are working together to do exactly that. And some of the outcomes that have been achieved in the real world. In part 3, we'll be talking about value-based care across settings. So we'll spotlight some unique challenges and opportunities in specific settings in terms of VBP programs. And in part 4, we're going to focus on real-life operational examples of VBC, concrete examples of things that are being put into practice in real-world scenarios and the outcomes that are being achieved. So please be sure to join us for subsequent sessions. And with that, we'll open it up for questions and answers.
Okay. Thank you so much, Janine and Erica. This is a very informative presentation. There's a lot here. And as a reminder to everybody, we're going to be sending out a link afterwards where you'll be able to review the session again if you like, or share it with colleagues. We hope that you do, and also the deck for download. So you'll be able to get this information. But yeah, let's dive into some audience questions here. And if you do have a question, go ahead and submit it now using your control module. And we're going to get to as many as we can. And if we don't get to yours, someone will reach out via email afterwards. So, okay, first question here is, one of the things we frequently hear from providers is that VBP or value-based programs create a lot of burden for them. How can we reduce that burden to decrease the resistance from providers?
That's a great question. I can take that one. So, having come from a provider background, I certainly could see that and experience that myself. And I think that when we implement value-based purchasing programs, P4P programs in particular, we often kind of experience that initial kind of resistance from the providers. It's almost a default assumption that it is going to be more difficult for them to get payment in these programs. One of the things we advocate for to decrease that resistance is starting to talk about these programs very early, stakeholdering, right? Getting people together and getting them to express their concerns and truly listening to them as a first step before we even talk about what a potential design of a program might look like, or what measures might be included, or how they may be evaluated. They really need to be heard. And the other thing that we advocate for is designing a program in a way that by design decreases the burden on the providers. For example, using quality measures that they're already used to tracking and addressing in their organization. Collecting data in a way that doesn't add a lot of burden to them. For example, you could decide that you want to, for primary care, for example, collect certain measures that their EHR is not capable of exporting data that would be required, to calculate. And that would require them to engage with their EHR vendor and do a proprietary data export or do some sort of self-reporting of data. Those are burdensome practices for a provider. So being cognizant of that and understanding what their workflows are and what their issues and challenges are, and how things that might be required in these programs would add to their burden is really important.
Wonderful. All right, next question here is, many providers are struggling with workforce shortages and increased costs, especially for smaller and rural healthcare providers. How have you seen this addressed in value-based care programs?
Do you want to take that one, or you want to take that one? I could take that one. So that's an interesting question. Workforce shortage, of course, as I mentioned, is everywhere. But especially we see it in rural and urban programs. And with the hospital VBP program we recently launched with a state, we saw definitely differences in that area, in the very rural areas of the state. So much so that we actually designed some of the methodology differently for the very rural providers than for other providers. You have to be really cognizant of any requirements. For example, if you're going to implement a structural measure, I'll give an example of one, providing a brief intervention for substance use disorder for encounters in the ED. And you need to be able to staff the ED with someone 24/7, 365 who can provide that kind of intervention. And you don't have the ability to do that because of staffing shortages in certain areas, then you need to think about how you would alternatively evaluate that area for those hospitals. Just be really honest about what that availability is. Keep monitoring it, right? And keep a finger on the pulse of it in case that changes. But you really have to think about, again, it kind of gets back to the last answer, understanding providers and their workflow and their challenges and their needs, and how those might differ by different types of providers is really important as you're making those decisions. And very often those kinds of things will come out in the data analysis. So when we're designing a program and looking at potential measures, we do extensive data analysis. And based on the findings, we'll ask a lot of questions, and we may probe, and we may have focus groups and ask our stakeholders, why do you think this might be showing up, or this pattern or this trend is showing up in the data? And most often they know the reason behind that and can identify that. So that leads you in a different direction.
Wonderful. Yeah, great answer. Okay, next question here, moving right along, is how much effect does the timeliness and standardization of claims data affect predictive quality measures? And what are some effective means that some VBC organizations are doing to tackle these issues?
It has a big impact, I think. I think that what you're really looking at with some of the programs we've designed is what we call real time, because being able to design a program on data that's a year, 2 years behind is really hard in the current state, especially we just saw a public health emergency, right? So there was a lot of lack of predictability. I think it's being able to really have something and creating a timeline. We, in some of the programs we've worked with in design, we have like a 90-day gap of where we're looking back because it's more real-time data, but also getting that feed. I mean, I know with claims data, there's a lag, and being able to build that into your program because it does have an impact and does have it. So being able to set a finite set time period, like I said, we tend to operate a quarter behind in a lot of what we do, which is more real time. But again, it's just for that period to really reconcile the data amongst payer and provider. Because again, if you're using 2-year-old data, that's not necessarily reflective of today's situation. So being aware of that. So it definitely has an impact, and really using a defined timeline. I think that's really the transparency, because again, if it's an unpredictable timeline that you're doing, taking into that consideration and building it, with a frame.
I would just add, in terms of building predictive models, that's probably a whole separate webinar that we could do at some point, and we'd love to do that. But that's where the data science comes in, right? And it's very important to use sound practices to build these models. Sort of feel like analytics is the new buzzword. Everybody's doing analytics, and anybody can use ChatGPT, right? and anybody can use these platforms that create analytics. But what's really important is having the subject matter expertise and the ability to really vet a data set and understand maybe why you're seeing some of the things you're seeing in the data. And standardized claims data does tend to be by definition standardized, which is a positive for building models. Using standardized data brings some efficiencies. But then we also take it a step further and we look at, okay, what is the data set, the standardized data set we're looking at using actually look like? And we run some tests on it to see, okay, is the data in that standardized data set valid? And are the data fields being used consistently within the data set, and all kinds of things like that. And that's part of the process of building a model, is really understanding your data and which data you should use, how much you should use. You know, the technologies are pretty amazing that we use, but there are different types of technologies to use to build a model. And so understanding which one should be used based on the data that you have is one of the keys to building a good predictive model. And then of course testing that model to see if you have, you know, reliability and validity and predictive accuracy. And there are certain measures of predictive accuracy, of predictive performance, I should say, that we use to ensure that, you know, we have a sound predictive model. And the data set is very important to that process.
Great. So we have time for one last question, which I'm actually going to ask to both of you. But because of the lack of time, I'm going to have you just give us a really short answer each to this last question. And the question is this: what is the most promising area of value-based care right now, like a specific line of business?
Oh, the area. I would say, so I don't know if this is exactly the answer you're looking for, but I would say the willingness I'm seeing in providers to collaborate with payers and other partners in pay-for-performance programs. I think that's kind of the most promising thing that I've seen. So it's not a specific area, but just that willingness to work together towards common goals.
I would concur. I think the two areas that you're really seeing is just being able to start pay for performance, especially amongst hospitals and primary care. We're seeing CMS really coming out with a lot of push in those two respective areas because they are large expenditures, but it's better coordination and better quality for the actual members or patients.
I'd have to agree, and I'll have to throw in my own here, which I think is all the implications with AI that are coming out. There's a lot going on that's very exciting there. That more to come about that. But I think it's a very promising application in a lot of different areas of value-based care, from data analytics to even service providing at point of care. So, but anyway. That is unfortunately all the time we have. We do have some additional questions, but don't worry. If you submitted a question, someone is going to reach out to you and answer that question for you. So even if you have one that you wanted to ask right now, go ahead and submit it, and someone will get back to you later. But I wanted to quickly thank our speakers today for the wonderful presentation. Thank you, Janine and Erica, both of you. As we close out here, I wanted to encourage you to head over to vbcexhibithall.com and you'll be able to visit the NetHealth virtual booth there. And there's going to be a link to this in the slides that we send out. But at this virtual exhibit space, you can read more up on them and about the resources they have and the services that they're doing. They're doing a lot of really cool stuff. So you got to go check that out. And there's a lot of other great resources as well at the VBC exhibit hall, including our resource library, which is where you'll be able to also find this webinar archived along with all of our other webinars. And then finally, if you'd like to reach out to our speakers or to the NetHealth team, feel free to do so. And their information is here, or at least Erica's is, and you can reach out to her and she'll get you connected. And if you'd like to reach out to me, I'm happy to facilitate an introduction as well, whatever is easiest. But thank you all again so much for spending your afternoon with us. Hope you join us for part 3. Keep an eye out for that, and we'll be sending information over on that soon. So thank you again for joining us. Have a wonderful rest of your week. Bye-bye.